Hello again. So this is part two of a two-part presentation and then the question and answer and discussion that follows. So this is the question and answer part and the discussion. And I would recommend watching part one before you watch part two. Um, so in this part or in this section, I think some really important points come up. And so one of them is a term that Dr. McAvoy uses. She uses a term called clearing the deck. And she said that the doctor at her clinic uses this term. And I have a similar term. I call it the hierarchy of problems with brain injury. And so if you accept from part one these different levels of brain injury problems that exist, the hierarchy idea or the clearing the deck idea is that you have to deal with certain brain injury problems before you can deal with others. In my experience, I know I had double vision due to cranial nerve damage, and I couldn't focus. I couldn't get even into starting to work on my cognitive rehabilitation, or at least the effort to do it was exceedingly difficult until the double vision aspect was dealt with. I think this kind of problem exists with all types of injuries, to visual systems, to vestibular systems, to balance, to all these migraines, headaches, all these levels of what can be injured in a person's brain. So the if you accept these levels or this pyramid, it's a lot more beneficial and effective to deal with the certain lower levels before you can deal with the higher levels. Within this, there's an interaction of the brain injury problem. So any brain injured person I've met has multiple problems, and if you look at the pyramid in these different boxes, the problems don't just sit within themselves; they interact with each other, such as with this hierarchy, such as with the clearing the deck. But there's also a very strange interaction between them that I've only been able to talk with other brain injured people about it. I don't think people without brain injury even know about this. Another problem that comes up, or another problem that gets exemplified really well in this discussion that is about to come up, that you're about to watch, is all the different levels of misunderstanding with brain injury. So the can't versus won't is a very big problem. Also, people not having a grasp of what the issues are, not knowing how to deal with a brain injured person, not believing them. That's just there's just layer after layer, problem after problem. I should probably not use the word layer here, but there's just misunderstanding after misunderstanding that comes with brain injury. And since you're brain injured and being misunderstood, it's really a double whammy of issues. And the last thing that I think is exemplified in this discussion, so in the National Academies of Sciences report on TBI, the Roadmap to Recovery, they speak about this. They speak about there's the haves and have-nots. And what that means is there are good clinics out there, there are good experts out there that are actually helping people with brain injury, but for the most part, many people are not getting the right help or not even recognition that their problems exist. And this problem is very clear. It was from my experience I felt this, and also a lot of the people that I've recorded in my podcast discussions. The people who are supposed to be helping us have no idea what we're dealing with and don't know how to help us. So Karen McAvoy and the clinic that she's with are a good example of the haves. They have a good way to assess it. They have a good way to understand this. They have, they believe the people who are brain injured, and they're able to help them. Versus many people who are the have-nots are completely disregarded. They're just not helped in any way that is effective. So this is a big problem that is very clearly exemplified in this discussion. I have one more point to say. I'll say at the end of this part two.
Yeah, can I say something?
Um, yeah, yeah.
When my injury happened, I was attacked by a dog and was unconscious for an hour, bleeding from my nose. And these people took about 4 or 5 hours to get me to a medical facility. And when I got there, I remember the doctor being on the phone with somebody going, he didn't know what to do. This was over his head, no pun intended. All I knew was that so I spent 3 or 4 years going to the U of O, dealing with memory processing, how to read again, things like that. The whole much of it had its basis in speech pathology, and the principal things that helped me more than anything, none of it came out of very little, I should say, came out of Western clinical medicine. I have found Western clinical medicine for the most part pretty worthless. What got
Randy,
me through it was acupuncture, a good acupuncturist, Tai Chi, which is not about the dance, and table tennis, and then the sensory learning. And I just don't think you're going to get much of it from Western clinical medicine, because it's not, people aren't trained for it.
Yeah.
However, I think the reason why this speaker is here is she's focusing on a clinic that is providing that training and that approach that's been lacking.
Okay.
And I would, though, ask another question based on what you're sharing here, speaker, because it sounds to me like maybe you have additional requirements for sensitivity approach training for the OTs and the SLPs, because for me, some of my greatest trauma has been those very disciplines who really don't believe the patient. And so, and there was another question from another participant about visual occupational therapists or vision occupational therapists. Maybe you could put that
Yep.
all.
Okay, let me answer these first. I totally agree with what you guys are saying. I understand the balance between, the medical science of it all, and then the actual treatment of what works for people. I'm in a clinic here where we are developing and working with, whatever works for a person. We have a lot of people in acupuncture. We have a lot of people in neurofeedback. We have a lot of people who choose to do kind of alternative medicine, and that's okay with us, because what works for any different person is fine. Table tennis is wonderful. I've not heard that before. I don't have any patients who do that, but that is perfectly fine. I spent a couple of days prepping for a trial this week that I had to go and defend one of our patients with this integrative approach that we do here in this clinic against a standard neuropsychologist who comes out of a standard university, who basically said there's no research that says what you're doing, that is right, and that you guys must just be a bunch of imposters who are, trying to, tell people that
I would
they can
submit
make
that
you better.
guy's the imposter, but go ahead.
Well,
But they don't know that they're
would
the
agree.
imposter.
Yeah.
So basically, I agree. I think that we need to look beyond just standard medicine while we simultaneously study what we can, and keep moving this field forward. I just know that myself as a clinician and as an educator, when I work with schools, this is what is helping people. This is, and whether it's backed up in all the science, I couldn't go into court and say, but this model that we're using here makes a lot of sense. And it opens up the door to people saying, oh, okay, I can help. I know that I can do something to help this person. So I would agree with that. Now, to Nancy's question, you're right in terms of finding the right people. We see a number of people here who go to different OTs or PTs. OTs fairly new, so mostly PTs. And unless you're really specialized in this area, you might not be that effective. Some of our people who don't see our specialized PT and OT don't get better, because this field really has evolved over time. From when I started at Rocky Mountain, we got our first vestibular physical therapist, and we were like, oh, wow, this is great. And now in the clinic I'm at now, wow, the RPT is fantastic. And we have an OT working on that eye tracking in a way that I have never seen an OT work before. It is, and our people are getting better.
What does OT stand for here? For
Occupational therapist.
I had occupational therapy for 30 years ago.
Exactly.
So
But don't think of the old occupational therapy as a field is training on working on hands and working on daily living skills. Can you take a shower? Can you prep a meal? That kind of thing. That's not what our OT works on. Our OT is very specialized in how the eyes are converging, and how if you are trying to focus on something like your computer or reading, and your one eye will kind of go out or shut down, and then your brain is not getting the feedback. So it's a very specialized type of occupational therapy. And all I can say is that we currently have this incredible woman who's doing this very ocular motor therapy. But if we ever lost her, I don't even know how to replace her. I don't know another OT who does what she does.
You can have similar injury to other sensory systems as you can to visual, or visual can be more complexly integrated with, I guess, behavior beyond vestibular system, beyond vision.
Yes.
You can have gating of other senses, or you can have problems with hearing. I think everyone I know has a hearing sensitivity that drives us
Hearing.
crazy. So that needs to at
Hearing
least
is
be dealt with.
huge. Yeah. But that's another area that, again, we have a very specialized audiologist that we use,
That's
and
great.
not all the other audiologists. We have a very specialized neuro-ophthalmologist that we use, and not just your regular ophthalmologist. We have had to find the people who know how these things impact brains. And right now, it's a handful of really great people, and that's why our people that we treat get better. But it's not scientifically based yet. It's not researched.
It is researched. It is researched in, if you go to SFN or any neuroscience conference, brain system, brain system, brain system, brain system, brain system. There's many systems, and with a brain injury, you hinted or mentioned it. We have a lot of different problems, not just one, but many. And then there's other problems, like, for example, when you say you're not yourself, then where does that fit into this?
Right.
And they're not going to even have an answer. Right. But if you think of all these parts as being broken,
right.
and
that's going to fit in clinical psychology, right? And then how do kids do at school? That's going to fit in school psychology. And I have to tell you, being on the stand yesterday or the day before, the neuropsychologist said that nobody should be treating brain injury except for neuropsychology, and clinical and school psychology should not be seeing any people with brain injury at all.
That guy should be fired, pure and simple.
I have like 5.
I'm sorry. That guy is an educated idiot.
I have about 5 interviews with people where they talk about going to that neuropsychologist, neurologist, neuropsychologist, and the person is not aware and denies what they're literally denies it. And that's where my trauma is. And I was going to ask you about the judgment, but you have the word judgment with bricks on your slides. And I'm like, that's the thing that I faced until I learned to hide my problems, because they weren't going to help. And I think everyone I know with a brain injury has drastic levels of problems with that. So yeah, we're all on the same page, just from a different side of the experience. I was going to ask a question. The different stages across your model, do they change and improve in the same ways or in different ways, like different time and different duration? Or is it too hard to say?
Oh, I think that's a good question. I don't know that I can break it down for you, but I would say when people come to us, so for example, let me just use this kind of case that I was just in trial on. Right after this young person had a brain injury, she was immediately sent to cognitive rehab with a speech therapist. She comes to us, we're almost 4 years out, 3-something years out, and she's not better. In my opinion, that was speech therapy, and cognitive rehab is great, but you can't benefit from it unless you are, first of all, clear the primary processing issues. If she's seeing double, if because her one eye is going off all the time and she's getting headaches, if she's nauseous, if there's an ocular motor issue or an inner ear vestibular issue that has not been assessed, identified, and then treated, she's not going to be able to benefit from word lists of memory and attention strategies and doing Sudoku. So what I wrote in my report was that I thought that first of all, that fatigue, which comes from all these things being out of place, will get better with primary processing. So you got to make the fatigue better. You got to make the symptoms better. And then you will be able to benefit. You will see a spontaneous recovery of memory, attention, all those other things will happen immediately, or will happen after that. And then if those are not getting better enough, then I refer to cognitive rehab, which is with a speech therapist.
The model you have is consistent with my experience and also how I viewed it, because as you get these other things, I remember being with my speech therapist, working on cognition stuff, they're not worried about my double vision as well as the other issues. And when the other issues went away, then that shifted, and the shifts inside your head are very clear, very strange. And it's like Randy, you describe as the windshield is cleaner, but you don't even know what the
Yeah.
windshield is.
Yeah,
And
it's like the Claritin commercial.
right, but it's definitely not clear. And brain fog is discussed, but this is, and yeah, there's a lot to discuss, but this model of thinking about it is consistent with how I view it.
I have a question.
It's very complicated. Yeah.
Oh, yeah, sorry, we didn't get back to your question. Go ahead.
I'm a person who never goes to see doctors for physical therapy and occupational for anything. But I've had the brain injuries. My question is this: how much healing can you do on your own? Because your body wants to
how much
heal.
what?
There's no
Healing
question
on your
about it.
own. How much
Healing on your own.
Yeah.
And what would you be looking for? What would you be doing? My arm doesn't work very well, but it only likes to exercise when I do dancing.
Mhm.
It wants to enjoy the exercise. So I think I'd like to hear more about healing on your own and what would you be looking for to do?
Mhm.
Because first, it takes a lot of energy to go to doctors, and you're often disappointed.
Yes.
So I wouldn't even begin to do it.
I will try to answer that question, because we do see people who come to us years later and they have healed on their own as much as they can, and they have made some gains. I don't know that I can be very specific and prescriptive on what that is, but I do think an OT who knows what they're doing, or a PT who knows what they're doing, who can say, here are some ideas, do this at home because I know you can't come in to see me. I would love to see that you have some more things, direction to do these things at home so you can get better faster. However, the brain, and people are very resilient. I mean, a lot of people figure out ways to do it, and the body acclimates pretty well. It's just that the body can acclimate and not get you as far as you could go all by, if you had some support and help.
I think to some extent that involves how much physical movement you're engaged with.
Yeah. Well, and so then back to what that made me think of what you were saying about symptoms. Yes, we protect ourselves. If you're reading and you start to get dizzy, we tend to stop. But there has to be a balance with that. That we used to say if you had, a concussion or a brain injury, you need to sit in a dark room and do nothing. Well, we know that doesn't make you better. And we know that if you don't stop and, you're going 100 miles an hour, that doesn't make you better. So, but there is a new concept out there, and it's based on a book called Run Towards the Danger. I don't know if you've heard of that, but it's a book about a child actor who became a director. This is an autobiography. And then the last chapter is she had a concussion and it impacted her for 3 years. And she went to the University of Pittsburgh Medical Center. And the doctor there basically said, we can no longer just stop when we have symptoms. We have to run towards the danger. That's the term he used. And that's what she titled her book, which is that whole concept of, we don't want you to ignore your symptoms, but we also don't want you to be too afraid of them.
Would you just call that engagement?
What did I just call that?
Would you just, what you just said, would you just refer to that as cognitive cerebral engagement, however you want to put it?
Yeah, I guess you could call it that. I haven't heard it called that.
But it's different. It's different if I can add, because Ruth, I'll try to answer your question next or later, but running towards the danger is different because when you have a brain injury, you've got things that are scooped out of you, that are missing, that are not there, and it's really, really hard to deal with them, let alone assess and figure out what they are. That's the first 7 years I spent with my brain injury, is like figuring out what had happened. And when you figure out what the danger is, it's the symptom, it is the weak thing in the hierarchy you had in your main figure. It's when my attention is in this state, it's not working. Randy, your word of cognitive or whatever you use, that could be applied to everything. With brain injury, the symptoms, the parts of you that are broken, that are not working, is where the work needs to be put in.
Yep.
I don't use the word recovery. I use rebuilding, regaining, and redeveloping, because sometimes it really feels like you're redeveloping a piece of you, and it's so weird and it's hard to do.
Yeah, and Karen, don't misunderstand me.
Yeah.
I'm not trying to imply that any of this is easy. It isn't. Even table tennis was extremely difficult in the beginning.
Sorry for
Yeah,
interrupting.
and during, while you guys were kind of talking there, I was able to go back and look at the chat, and it just saddens me to see that you guys have had such bad experiences with speech language and OT, but I'm not shocked at all. I mean, until I got into this
person I've
clinic.
met is, yeah, I'd say everyone I met is like that, and the ones that aren't, the discussion is a cookie cutter issue where the speech therapist helped me with this or this or this, but the other things that were there are things that they just got used to or hid, and that's
Yeah, there's a lot of variables involved, but
Yeah.
exercise is a big part of it.
Yeah, I would agree with
And
all
the
of
other
it.
part of
And I
it,
think,
Karen, the other
Mhm.
part of it, Karen, that I would suggest that you might want to research in Colorado is to find practitioners who are well experienced, understand what they're doing with the internal martial arts, yoga, tai chi, any
Mhm.
form of meditation, or anything
Mhm.
that would fall under the contemplative sciences.
Yeah.
I'm
Oh,
not saying
yeah.
it's easy, but I'm sure you know that the prisons are filled with a lot of people, filled with people that have had brain injuries.
Yes.
Oh,
And
yeah.
most of that research has come out of Colorado. Yes,
Right,
we totally,
right.
and this model has been completely adapted for the prison settings. This is what they teach. We help people who are in prison go through this process to figure out if they've had one or two or how many lifetime exposures to TBI, get a lens on themselves that they have a skill deficit rather than they have a bad behavior. There's an entire curriculum called the AHEAD curriculum that is used in the prisons here in Colorado, which is those blocks that I just showed you, because what goes along with those blocks is awareness and then intervention. If I'm aware that I have very poor attention and very poor impulse control, then I can work on that. And that's the whole focus of this. So you're
I
absolutely
can't
right.
disagree with that.
the awareness is a huge aspect, and it's the same word I use.
Mhm.
We have a talk an hour long about the Colorado prison system brain injury problem in this series, but we didn't get into what you just said.
I think that we're moving forward, but we have a great speech language person here now, but we had two others before them and they weren't great. We have a great OT now. And so, like I said, if we lose any of them, I'm not sure I could replicate them, but something is working now and we're using this model and people are getting better. Somebody asked, our clinic primarily is a Medicaid, Medicare insurance clinic. And that's mainly what we see. Private insurance, we don't take. We do that just by self-pay, and we have a very low self-pay rate. And that's all we do. The name of the clinic is Asha Brain Clinic. And if you want to look that up, it's Asha Brain Clinics, plural.com. And you can see all of the partners that we work with. And I don't know that I can totally explain whether it's, it's the personalities of the people we have here or their specialized training, but they are doing a great job making people feel better.
I could
I will
offer,
also say, I'm
yeah.
sorry, our OT does a lot of yoga, does a lot of meditation.
Do a lot of these clients that have had these accidents, have they been through any kind of seizure disorders with these kinds of things? Because I've had a lot of seizure disorder, a lot of seizures throughout this. And when I have had some of them, it's really kind of slowed down not so much as I've gotten older, younger on, it's slowed down my therapy process, and I don't know if that's been a thing through any.
Yeah. I mean, we don't have a lot, but it does happen. And, whether the, seizures come from a brain injury or not, seizures in general are just going to be just really hard on the body, period. Hard on the brain. It's very disruptive and it, can set you back cognitively.
Yeah.
So,
okay. I just wonder if that's part of your
then you
therapy process or.
Yes. Then you have to kind of pace it forward when someone feels well enough to start up again with therapies.
one other question, do you ever do studies on your patients? You know, you have this many patients and, you know,
Mhm.
these got better, these got worse,
Mhm.
this, any studies on your
Mhm.
patients?
Yes, we are, we collect all our data and we are working with a very well-known researcher to analyze it and see what we can make of it. But it's in the very early stages. But yeah, we are a research clinic as well and teaching clinic. We have a fellow who moved here to train with me, so she can hopefully take this back to her home state and
Where are you
create
based
another
out of?
clinic.
Are you in
Colorado.
Denver?
Yeah.
We're in Fort Collins,
Fort Collins?
north
Okay.
of Denver.
Okay.
May
Thank
I ask a question about someone, I'm not sure which state, but who is housebound with a brain injury and physical deficits, how that person might seek care if they're on Medicare?
I would guess, I mean, that wherever that person is in that state, I would, always start with their Brain Injury Alliance to see what resources they have. I know some states have more than others. I mean,
The
there's
state
not,
of Oregon doesn't have much.
yeah, I don't know state by state. I know, I mean, it can be somewhat limited, but our speech person and our OT in our state they do telehealth for Medicare within our state. And then, of course, if it's physical, therapy that's needed, that's always hard to do by telehealth. But, some can be done that way virtually with our Medicare patients.
I think that's a
And
hard
I
question.
think Medicare does have home visit in,
Yes,
would that be
Medicare.
most states?
Yeah, well, I don't know, probably, but Medicare does have home visits. But like, for example, I saw a 73-year-old gentleman yesterday, 6 weeks post very serious motor vehicle accident. And he is getting in-home PT since he went home from the hospital, from inpatient rehab and home from the hospital. But the PT is very limited. I mean, that is not the specialized kind of PT he needs for brain injury recovery. It's probably PT for, some of his arms and legs kinds of things. And then, he's going to be discharged next week because they met their goals, meaning he can probably transfer and you get, use the toilet independently, that kind of thing. But he is coming to us because, once that PT stops, we would like him to get in and start to see our brain injury specialized PT if we're actually going to make his brain injury better. And that's that kind of difference in that specialized PT versus another. He's Medicare, and so he's received that at home, but now we'll treat him here with Medicare.
I see the necessity for supports to be there for people to even work on the things they need to improve as drastically missing. And some people get lucky, and socioeconomic status and finding the right professionals to help you is sometimes happens. And I know it happened for me. And then what you guys are doing is an even tighter net that is supporting. Like I'm thinking of different problems that you may or may not have assessed because I had them, and it's very frustrating to find the lack of help. But if you then have help for attention and other aspects, overall kind of things get lifted enough. And I noticed on your slides the judgment versus curiosity. For brain injury, curiosity, and Nancy has coined the term for us. It's like, I need you to be curious. I need the healthcare professional to be curious as they're helping me, because brain injury stuff is so different across each person, and that I think would tie the supports that you have together even more. The missingness of something like this across the board is drastic. The state of Washington has actually just kind of fallen apart with this. Roscoe, I'm here in Washington now, and I've been observing them, and it's getting worse and worse. The BAA got defunded. It's a bunch of stuff, but every state is different, and no state is really that good. Can you send us your slide? How do you spell Asha? But can I get your slides and
yeah.
share them? Is that okay?
Yeah, and I'll cut down all the other ones we didn't even use, and I'll send you a
Thank you.
smaller version of this,
Thank
and
you.
then feel free to share it with others.
Thank you.
ASHA is named AASHA,
Uh-huh.
and so it's our website is ASHA Brain Clinics, plural.com. And I work with Dr. Mistry, who named the ASHA, which means hope in Hindi.
Mhm.
And that's why he named it that. We have people who find us and on their first visit, they cry because they've never had healthcare providers who actually listen to them and understand what they're saying and don't judge it. We see this every day, and we say, we see this every day, and we'll do our best to get you feeling better.
Yeah, we see the judgment every day, the misunderstanding every day in a very frustrating way. So,
Mhm.
yeah, thank you.
Hey, Karen, if you ever need an advocate who's familiar with the legal system and everything else,
Mhm.
feel free to reach out.
Okay. Okay. It's
I
good
could
to
be
know.
I could be potentially deadly. But
Okay.
that's besides the point.
It's good to know. Yeah.
Maybe we'll do another talk next year. We have another alexithymia talk going to happen next year too, and we can get into the other stuff that you had mentioned today.
It's all in the public domain. Go to cokidswithbraininjury.com and download those building blocks. Download the manual for educators and just extrapolate it for adults if you need to. It's all out there, and then if you need me, my information will be on the slides, and feel free to reach out to me. If there's another topic, like if you want to talk about concussion management and how REAP works, I will, I can definitely come back and talk, but that's going to be more about kids and not so much about your guys' experience.
But what you're saying is consistent with our experience. It actually makes me feel so much worse for the kids, because I was 18 when I had my brain injury, but I was at least I just started college. I mean, I guess I was a kid too, but some of the people here though were kids when they had their brain injuries.
Mm-hmm.
So that is another layer.
Yeah.
Much to discuss. Yeah. Okay.
And when is the next webinar?
This
So I
is
can
it
tell
for
them
now.
about-
I don't have any more for this year. This is the last one.
Okay. And you're
I'm gonna-
starting again.
I got a few new people. I'm fucking exhausted. Like, I have the 3 videos I'm gonna put out. I'm not gonna worry about another webinar series until maybe in the summer I'll figure it out. But yeah, it's just taking a lot of time. But yeah, I contacted her over a year ago, and I saw her talk probably 2 years ago. And the non-brain injured people that were there, the clinicians, kind of like swept over all this stuff. And I'm just like, I hate being around these people having this discussion. So what she presented is very consistent with my views of the hierarchy of problems and the core problems and the nature of the weirdness of what we can miss. And I like her, she's like actually applying this to helping kids. So there's a lot here to discuss. Maybe once we put this out, I'll put it out on YouTube. We can watch it again and have a discussion about it, because there's so much stuff here. And
it was enough to like really like stir up emotion when she said it's not about it's can't, not about won't, and it's skill, not will. And like, I've known this, but even saying it to a practitioner is cause for further damage.
Right, because they don't understand what you're saying. And like, that's the thing that I learned to hide, because they don't understand what I'm dealing with. So I'm like, I can get help for this from this person on this level, but all these other things, I can't even explain it. If I try to, there's going to be judgment. And if I try to, there's going to be this inability to get them to understand it in a really emotionally difficult and frustrating way. And I don't want to deal with that. It's too hard to deal with. I guess it comes from them judging it or not understanding that there's something underneath that I need to fill to then do that thing. And I don't know. There's a lot of specifics. Yeah.
Do I have a negative bias against all doctors or most doctors? I mean, when she says things and people got better and people got better, I think, do you have a vested interest in saying people got better? How have you measured people got better? And I don't feel that way when my son reads to me about the Canadian health system. And they've tracked, people with concussions because they don't have that vested interest. They're not making money off their clinics or their medical practices. So when they do studies, I don't get that negative bias. Like,
what's the negative bias?
Well, when she says, and the patients got better, and I would think, yeah, maybe a third get better, a third get worse, a third stay the same. The measurement isn't there, and I know that she's promoting her clinic. When my son reads to me about healthcare in Canada, and they followed people with concussions or brain injuries, I don't get that negative bias because I know they're not making money off saying this is better or this is worse. They're actually just following, gathering data because, it's a national health system. So I don't trust private medicine or the way we have medicine, the way I do countries that, have medicine that you're not making your money off the clinic. You get your salary, and when you do the studies, it's based on whatever. I have more faith in what their results are.
I hear you, Ruth, because there sometimes is a financial motive. She is, though, coming from a state that has done, like what she said about the prisons wasn't her work. And what her clinic showed was compassion, which is lacking. And I still am not sure that they could help me, even if I moved to Colorado and went there.
And I think I appreciate her saying that people got better, because in many places in this country, they're not getting better, or there isn't an overall problem. There's still, like, the problem I had, and I wanted to say it then, Nancy, but I can say now, is the cookie cutter dilemma, that these professionals think this and this and this, and then they don't see anything else outside of what they think could still be applied to her she has a larger net. She has more cookie cutter views, but she still has these specific views. And then when things get better, they don't know why it gets better enough, but it's like things are overall getting better. Is different than many other places. Many other concussion clinics are not getting people better, and they have, I see even worse, that they see this pitching that you should accept where you're at and get used to it, which is not acceptable if you have a brain injury. And so she's actually helping people get better, but there's enough supports for it. They are applying an accurate model to the really, really simple stuff that got injured in us that other people don't even understand exists. I actually had no idea what she does. I just knew she did REAP and the.
It's interesting, and some of that, accessing your energy and how much energy it takes to do things.
The part that you asked about, how do you deal with it on your own? It's really, really hard, because my solution is like this. What are your core problems? What are the things in your life that are sucking out your energy, the biggest, hardest things for you? And then how can you build either a way to avoid them or learn how to rebuild them and regain them, which is the most energy. If you're working on a part of you that got injured, it's so energy draining. So then you need to have all these other things in your life supported so you can do that. And if you don't have that, then it's a different situation. Then it's most brain injured people who are on their own are in that situation. So she doesn't answer everything, but she has a great view of the nature of what got injured in us that other people don't even consider.
Yeah, better than others. And so did that other person from the University of Washington.
I know, he's the only, those are the two. I've seen one other person from the Mayo Clinic talk about stuff like this, and I wasn't able to get a hold of them. But it's a rare population.
So speaking of this talk, Daniel, when the speaker showed the slides that were the definitions of the blocks in her visual,
Yeah.
Where was that explained? Was it in the book she showed, or was it in the material that we would have to go somewhere else to see? And
I have no
if,
idea.
and when she sends you the slides, can you like ask her to include those definitions in the slides, even though she didn't go over them? Because I
Sure.
want to
And,
see 'em.
okay. Yes. And so I'm the way I'm thinking about this now, which is a weird spin-off, but I wouldn't mind going through some of these talks and discussing with people who have brain injury these kinds of things, because these are the kinds of things that get glossed over but is drastically important for us. And those definitions I can give you in a general way, but also based on what she has, I can access that. And it's not an easy discussion to have because it's complicated, it's a lot of words, and it's actually not complex, especially since we have injured those things, but it takes a lot of discussion. It's a bit of
So you didn't agree about that reaching for danger? You think, because
oh
that's.
no, I do agree, but it's not an easy thing. It's not just danger. It's well, okay, I don't know that person's book, but from my
It's like
experience,
the opposite of pacing. It seemed like the opposite of pacing.
but pacing is like what athletes do. Pacing is this term that fits for not brain injured world. When brain injured world is
Okay.
rebuilding the stuff that is so hard, so limited, so not working in us, that even doing the first step of trying to do it, even being aware of what it is very, very hard to do. But Ruth, going back to what you're saying, it's not, I don't disagree with her. I'm just saying that it's building what is missing in us isn't learning, it's relearning, and it's relearning how to deal with what is missing in you. I was agreeing with her and just saying that it's much more there than going into the danger, because you can have danger about feeling nervous about something. You can have danger about something that triggers you. You can have danger about the dangers are not specific enough for brain injury. Is how I view it.
So right now, I've been here a long time, and I have kind of head symptoms, uncomfortable, but it's so interesting to me that if I would leave it, I would feel like I was losing something. And that's why I stay longer than I should at places, because, I feel like I would lose things if I left early. If I have a conversation too long with somebody, it's because it's interesting. And I can't, then I would feel like I've lost part of my life. I'm living the days as well. It's
learning to not push yourself to the limit is very hard to do across brain injury stuff. And so I think you and I can have this discussion. I've been intending to call you. I can't get a free moment. Nobody's out there to help us figure out our own problems, and then the people out there that are there are hard to even get into this kind of a discussion.
Yeah, that's why I don't go to anybody, because I can't.
Right, and the people that she's
begin to
working with
explain this.
are better, much better, but they're still not perfect, but they're better. They're like a lot better. So
Two comments. Ruth, I hear you about staying too long and feeling like we're going to miss out on something. I'm guilty of that too. And people say, well, just go and get it later. But I know there is no later oftentimes. So I just wanted to acknowledge, I hear you. It's really hard. And
Do you
Leslie,
get physical symptoms, physical reaction?
well, for me, my physical symptoms are things that I like just muscle through. And then, like the speaker was talking about, there's an emotional breakdown, inappropriate behavior, that comes through because I can't muscle through. And so, yeah, it's really super hard. And people don't believe that there's stuff under it.
You said something else and I interrupted you. There was a second thing.
Oh, the second thing was, hi, Leslie, you haven't shared anything. How are you?
she's muted or can't talk.
I'm just listening. I'm okay. Yeah.
I'm glad you were here, and we'll talk on the phone, hopefully.
Yeah.
Okay.
Yeah. the speaker has enough view of the stuff that we're dealing with that to everyone else is invisible, that it's like there's a lot to discuss off of this presentation and discussion. That's kind of what I hope to make from this.
Yeah, and I think, Daniel, just to follow up on what you said, that having some kind of altered format that includes more discussion might be useful, but I'm not all for like not having more talks, because I think this does foundationally raise the awareness and the potential for care in the future.
Yes, yes. I
and
tend
we'll
to have
just
more
get
talks.
more
Yes.
specific about who, like the last two plus the Canadian one.
Yeah, I mean, the thing is, there's other good ones out there that maybe I could find a way to replay them for people, because I don't think everyone has seen them.
But, you know, but he was very much into pacing, and she kind of at the end was saying, you know, reach for danger.
But she did not deny that to pace it as well, because he's talking about specific to the fatigue. And so when the fatigue, it's not an issue that comes up, it's a sledgehammer, it's a brick wall, it's an inability to do this. So go into the danger. From my interpretation, from my seeing the other talk she gave, and also from the brain injured people that I've spoken to who have recovered, you go into the danger with the pacing. You go into the danger with the inability. You know that there's a limit that's too far, so you have to avoid that limit, and then you go into the danger by working on your problems. They're not the opposite. They have to both be had at the same time, and that's really hard to do. It's not like learning, it's like relearning, it's rebuilding, and it's her data on that.
It's rebuilding from doing too much and you know hurt your recovery. It's very, you know, the concepts are so vague.
Right. So the concepts are vague, but if you can nail it down, the method that I have adopted, which I'm trying to do, hey, brain injured person, let's sit down and talk about what you're dealing with. And the more you can discuss it and form a ball around the vagueness, then you can start to learn how to manage it, learn how to avoid it is a big thing, or figure out a way to baby step it. And the baby stepping it, that's a discussion that I have only had with like a few people, and it's even more vague. And then there's all the other examples, like Nancy with your CSF stuff, like that doesn't fit into this category exactly at all.
Yes, what are those initials?
Cerebrospinal fluid flow. But there's all these other just brain injury problems that are not fitting into, oh, that's on her list of those building blocks. There's other problems too. There's other, her top thing of reasoning, I injured that. So that's I injured that like the other things. I had to work on that like a thing to rebuild.
Well, she's doing very basic things. I mean,
but her hierarchy assumes this hierarchy. You can still have an injury to your cognitive system that creates the inability to have logic, the inability to have reasoning, and that needs to be worked on, just like the attention that's on the bottom.
She's just doing basic things, you know, just.
Well, I would say the speaker today, they're not just doing basic things. They're starting with the foundational to make sure that they're successful with the more advanced. That clear the decks thing is, let's look at the obstacles, the basics, because it's the part that most skip.
Right. And the clear the decks statement, which she said repeatedly, is a good way to give it context. I agree. I have a lot of emotional, I'm triggered by this because that model and that what you just said wasn't how anyone else ever thought about it. So I didn't have attention problems, but I did have other problems on the bottom of the list and other problems on the top of the list. And the hierarchy didn't exist for me. I had to figure it out in a way that was enough to learn to not push the limits and to learn to slowly improve them. their lens comes from being clinicians and working with people, and it's a good model, it's a good hierarchy, and it's by far more considerate of these problems that no one else even talks about.
A lot of people really, manage on their own. Not everybody sees medical professionals.
Or we struggle on our own because we haven't found people. So we manage
Right.
the best we can, but that doesn't mean that we don't need help, in my
Right.
personal
No, if there was something that I thought they know what they're doing. I would say that the guy from University of Washington, if his clinic was here, I might go to it. But I don't see anything in Eugene that's going to be.
I don't see anything, period. I see it across this clinic in this country and this clinic in this room and this. So it's very scattered. It doesn't really exist. The discussion about it to help you to manage what you're doing, I can't have that discussion right now, but the idea is, what are your symptoms? What are your biggest problems? What are your resources and abilities? And then you try to find a way to work on it. We did it your first round of brain injury stuff before your new stuff. And then it was easier because it wasn't as bad. And Curtis and I had a lot of things that we related on because I believe we had to come up with the same solutions or the same, it's like a bird's eye view of the solutions. And then we tried to share it with you. So it's a hard discussion to have.
Are you seeing someone now to help you, or
I'm
I was
working
thinking
now
that
with a
way.
clinician about this emotional stuff, but she's, to put it bluntly, she's the best I could find, given that I couldn't find anyone to help me. And it's just become weekly discussions about the feelings. And she's good at feeling stuff and she's helping me. And she's kind of a behaviorist, but she gets how different brain injury stuff. Oh, Nancy, you'll love this. She's been going to these talks at University of Washington, this brain injury series, and I've viewed a few of their talks and they're horrible, missing the points. And she said that the last one she went to, she said, what would Daniel think? And then she started asking them questions at the end, and then she basically came up, but she didn't have the word. I gave her the word of, they have this very cookie cutter perspective of depression post brain injury, and all they're really talking about is pharmacology. And she's like, she could see that there's something was missing. And it was like, yes, like that's, it's almost like I'm teaching her how to think about it.
And you
Hooray.
are, because it's very different.
So it's one person. That's one person, and that's my therapist. And but she came up with this, like, they're only talking about this, and the discussion was good because in the end I was like, brain injury and depression can be thought of very simply as we get so depressed because we don't get any help for all the problems we deal with, and then
Right.
it's like that's it.
And take our depression away, we still won't have help for the problems that we're still dealing with.
Right, but the depression, it's not like I'm in the depression from the first day. I'm in the depression over time, and it was.
Yeah, it's discouraging to feel like all that work and maybe one person is beginning to learn. However, it's important and it's worthwhile, and that one person hopefully won't keep it to herself, and she'll share it and make a difference, and it will ripple from there. And that's the best model I can live by.
Yeah, that what you just said, this presentation's cookie cutter is big enough to encompass a lot. But then somewhere along there, I need to make the point that it's just still a cookie cutter and that there could be more applied to it. But at least they have these bigger picture perspective.
Yes, breaking out or smashing out of the cookie cutter is the title that just came to me.
That's a good one. That's a good one. I also, I was telling my son I feel better after I cry, and he said that's because you get endorphins after you cry. I didn't know that.
Yeah,
So,
and depending on your
cry because you get endorphins.
Well, also you
And
probably have
depending
pain.
on your injury, you may not get the same endorphins. It doesn't do the same for everyone. That's the classic model, but we don't all fit that either.
Yeah, okay. No, because, yeah, you do, I mean, I feel better after I cry, you know, it's,
I think there's a huge amount of emotional stuff that comes with all of this, and to cry and get it out, it's a necessary thing. I can relate with that. Yeah, all I'm saying.
you know, another reason I don't trust doctors, the anesthesiologist never asked me, all he asked me is, have you had any surgeries? No. And do you take any drugs? No. Never asked, did you have a traumatic brain injury? Maybe we shouldn't give you this, maybe we shouldn't give you that. It was very sloppy.
You're
You
probably
know,
angry
not
at
so
that.
much you never want to sue them, but I thought, I don't want to get near medical people. All they want to do is give you drugs that are just going to make me sicker.
Well, it is important for, I mean, I've had a lot of surgeries, and yeah, I'm concerned when they're not interested in that enough. But when I tell them what my concerns are, some of them say, whoa, I better read up on that. I didn't know. And so they don't, they
I
start.
don't think we know a lot of people.
Well,
Yeah.
they're not all
Well, they
those
don't care. You know,
even in
they're
the
busy
file.
doing-
They don't even have access to all those things. So it is the patient's, still the patient's responsibility to make sure that you
Oh, I
express
haven't,
your
yeah.
concerns.
I don't plan on having more surgery. If I break something, it's just gonna get taped. I'm not gonna have to take any, no, it's not gonna take drugs. Because it affected my central nervous system and it brought back my head injury that was doing so well. I mean, I was taking Russian at, you know, college level Russian.
One thing
Yeah.
that came up in the talk, and I wanted to say, but I didn't say it, was in the National Academies of Sciences report, the first talk I did this year, they have all these things that they talk about because they know about it with research, and then they have this general statement about that they need to research what the brain injury people are using, and it is very not super condescending, but condescending enough, like academics can do with. They don't know about the benefits of exercise, nutrition, and sleep, and I would add to that the support groups for brain injury. And those are 3 or 4 things that the brain injury people I know and I myself have figured out, and it's so
Me
necessary
too.
for it. So beginning to have activity isn't going to save you, but it helps in a certain way. And then I think the support group, but also with the emotional stuff, is dealing with that so that you're not, I don't know, there's a gruelingness to this if you're alone with it and so depressed and have no ability to let out the emotions because it's constant problems that lead to these emotions. So crying, I think, helps with that, and talking to us helps with that. And they don't know about it. The non-brain injured world doesn't know about it because there's no research about it. So I think that this Q&A discussion and everything that followed after Karen McAvoy's presentation is it's a really good example of what brain injured people are having to deal with. And although each brain injured person is dealing with something different, there's a lot of common ground and a lot of similarity. So I think the combination of part 1 and part 2 from this seminar would be very helpful for anyone who's trying to make better sense of brain injury. Maybe you're brain injured, maybe it's a loved one or caregivers or other clinicians that you feel like don't really get what brain injured people are dealing with. I think that the combination of these talks is a really good example to share. So with that, I just wanted to make one last point. And in this discussion, there's the woman who's at the brain injury support group. So she asked a question about the running into danger versus pacing. So pacing was an idea that was brought up in the last Building Brain Awareness seminar by Dr. Nick Dasher, who spoke about the fatigue with brain injury. And he speaks about pacing in terms of learning to not push your limit and learning that when you're dealing with brain injury problems, you have to learn to pace yourself and not to push your limit, because if you push your limit, you'll get into this exhausting fatigue that is completely overwhelming, and all the gains, all the work that you've done, it just kind of falls away because the fatigue and the exhaustion is so drastic. I had this problem, and what he presents in that talk was very consistent, very similar to what I learned about 4 years into my brain injury to learn to not push myself to my limit. And so in this talk, Dr. Karen McAvoy speaks about this book about running into danger, running into the danger with brain injury. And I haven't read that book, but I can say from my experience and from my discussion with many brain injured people, the danger part is the idea that what is injured in you, your core problems, the parts of you that are not working, are the danger. And in order to deal with them, in order to regain them, in order to exercise them, you have to run into it. You have to try to do the thing that is extremely hard to do. And in my experience, that has been the hardest thing I've ever done in my life. And in the first few years of regaining my cognition and regaining my abilities to think and to put information into my head and just get, problem solving the step, just to get the activity in my brain to happen was absolutely exhausting. So Ruth asks, how can you both run into danger and pace? It doesn't make sense. And I think she's right in that respect. It doesn't make sense from a non-brain injured perspective, from an unbrain injured view. But the idea is that the running into the danger, it's not really running, it's baby steps. It's very small steps. When you try to do the things that are injured in you, it's exceedingly difficult. So running into it means just doing that one effort where you try to do a tiny amount of what you cannot do. In my experience and in my discussion with other people, the first time you try to do it, it's exceedingly difficult. And then if you can do it once, you can do it again. And over time, we're talking about repetition across weeks and months and even years. Over time, it does get better. And learning to do that, learning to pace, meaning not to push yourself to the limit, that becomes the running into danger with brain injury, because it's so hard to do. So it's like you're running, but really you're just doing a tiny bit of effort. Another thing that is unique with brain injury is that these aspects of what you're running into, what is the danger, was once automatic, was once something that you never even thought about. So it's just very hard to do it. But I think that's the best answer I have for that, for how to pace by working with what is missing in you, but working at it at a very, very slow baby steps, and then learning not to push yourself to the limit. That's the most important thing. So that's my best answer for that. Thanks.